Welcome to another one of my talk you through a podiatric sports medicine intervention. Join me here at Leica Health Orpington Clinic, where I'm about to perform a high volume hydrodissection injection of an Achilles tendinopathy. This lovely young lady has been suffering for approximately 5 years. She has had a series of treatments, including physiotherapy and shockwave therapy, and she has actually had a Haglund's deformity surgically reduced. She is still suffering with ongoing Achilles pain, and she continues to run recreationally 3 to 4 times per week. Traditionally, a high-volume hydrodissection injection has been described for the use on mid-portion Achilles tendinopathies, and I have found this injection to be a very good option for insertional tendinopathies. Also, these work best if there is neovascularization, similar in pattern that you would get on a mid-portion, but it offers an intervention that, although maybe slightly less predictable than a mid-portion, and its outcomes has offered significant benefit to my patients and gives us another option in our toolbox for treating this problematic condition. This lady does have some calcific changes at the insertion following her surgery, and we're hoping that we can still achieve some positive benefit. Reassuringly, she does continue to run though, so we're not considering this as one of the most painful options, and she has no tearing and actually has a healthy collagen fibre alignment when we've done our ultrasound scan. As you can see here, I have a lower needle position. We are injecting through the medial ankle as I prefer, and this way we avoid contact with the sural nerve. The tibial nerve sits more anteriorly, the tarsal tunnel. We can comfortably avoid this when performing this injection. Thankfully, as it's the left leg, today I'm performing this right-handed, which is much more comfortable for me to do. Initially, we inject local anaesthetic and a low volume corticosteroid, and then the rest of the injection is made up from sterile saline. Effectively, we're trying to break off soft tissue adhesions to the Achilles tendon, reducing the neovascularization, and in lay terms that is probably a visualization of inflammation. Well, it's strictly not true in the truest scientific sense, but to the lay person. It is important when performing this injection that the tip of the needle is never moved when it's out of sight of the ultrasound. I like to periodically check both transverse and longitudinally the Achilles tendon, and check the level of neovascularization as we progress through the injection. As you can see, I'm doing here. Make sure the needle is in plane with the ultrasound probe before we move the needle again, and we're very gradually moving the needle and bursting off adhesions around that insertion area. It's important to remember that you're likely not to be able to utilise as much volume of fluid in an insertional case, and certainly I don't remember utilising more than 20 mils of total fluid volume in an insertional case, whereas up to 50 can be used for a mid-portion. Each patient will be different, and I like to judge this on the back pressure on the syringe. And there comes a point when the tissue no longer wants to stretch any further. The needle tip never touches the Achilles tendon itself. We always maintain a margin for error on that. That's why we never have the needle tip out of sight of our ultrasound when we're moving it. This injection is almost completely pain-free for most patients. There is a discomfort and a tightening sensation, usually as the fluid pressure builds up. This can't be anaesthetised with local anaesthetic, and patients are usually aware of this. It's not usually too uncomfortable, and is usually tolerated well. Aftercare after this protocol, my protocol is that we have 3 days with relative rest and no rehabilitation. On day 4, we begin some basic exercise rehabilitation. No running or explosive movements are permitted for at least 7 to 10 days. So this lady will begin her rehab again, and I've prescribed her some altered rehab exercises to her prescribed plan. She'll begin this in 3 days' time and return to running on Tuesday of next week. And I usually advise a graduated return to running program rather than shocking her Achilles by returning to her full load immediately. I counsel all my patients that this procedure is an adjunct to their strengthening rehab program, and that is forms the basis of any treatment, and this only enables her to progress through her rehab with minimal discomfort, and enables her to remain pain-free, hopefully for several months at a minimum. It's important to remember that with insertional cases of Achilles tendinitis or Achilles tendinopathy, that these do not like stretching exercises, no matter how tight gastroc-soleus complex is. I would counsel any professionals providing exercise rehabilitation to not get their insertional Achilles patients stretching, certainly not when they're in pain, as it is only provocative to their symptoms and serves no beneficial purpose. Their loading should be in a plantar-flexed position, and I would have them plantar-flexed throughout the day with a heel raise on both sides. Injection is complete. If you have liked this video, then please like, comment if you have any questions, and subscribe to the page, where I hope to keep making this content, provided my followers find it interesting. Many thanks to you all, and hope you have a brilliant day.